Thank you, Crystal. Right. Okay. What we are going to be covering today is leadership in healthcare, why it matters, and how we go about influencing our colleagues. So that's what we're going to be covering in this session. So I wanted to first look at leadership as in general in healthcare. I'm not going to go in a lot of detail because I'm sure a number of you have already done leadership courses. But just wanted to point you in the direction of the King's Fund, who've done a significant amount of work about leadership and how they talk about the value of clinical leadership. And for you guys, because the majority of you work in clinical roles, frontline roles, and you're all clinicians. And when you've got leadership from clinical people, it's always associated with higher productivity and better organisational performance. So your role as leaders is really, really important in healthcare. And the King's Fund talk about collaborative and compassionate leadership. And how that plays out, how that's seen in the workplace is in these 4 bullet points there, by attending. And what they mean by that is by taking the time to listen to the challenges, the obstacles, the frustration and the harms that colleagues experience, as well as listening to the accounts of their successes and their joys. So when you're listening, attending means that you're always listening there and wanting to hear about what they've got to say, both good and bad. With the understanding, it's about implying that you value and explore conflicting perspectives. I think it's really important not to surround yourself with people that are yes people, and making sure that you listen to those people that might have the contrary argument to you, so that you've always got a variety of people's viewpoints around you. Empathizing, I think we're all clear about what that means, about having the empathy with our colleagues. It's not about sympathizing. It's about being able to understand how things are feeling from the other people's perspectives, mirroring and feeling their distress, joy, and frustration. And then finally, the helping element of being collaborative and compassionate is about having that thoughtful, intelligent action. And that means being able to remove the obstacles that get in the way of people doing a good work and doing their job. And for example, that can be chronic excessive workload, conflicts between departments and in departments, providing the right resources that people need and the services that people might need to be able to do their best in the jobs that they're doing. That could be staff, that could be equipment, and that could be training. And that's often thought to be one of the most important things that you can do as a leader, is be there to help. I don't know if any of you have ever watched the TV series New Amsterdam, but their medical director, when he came in new, the first thing that he always says to people is, "How can I help you?" And I think that sends quite an important message to your colleagues that you want to be there to help them and to lead them. Let's move now to leadership in IPC specifically. And the National Institute for Health and Clinical Excellence have quality standards that set out priority areas for quality improvement in health, public health and social care. And these are sets of statements to help improve quality and information on how to measure progress. And it's not surprising that they have one around infection prevention and control. And their quality standard 2 is this statement here. And they're very clear that leadership underpins all infection prevention and control and is vital to ensure that this remains a priority for the organisation as a whole and each person working within it. Well, we know that COVID absolutely was a springboard for bringing infection prevention and control right back to the forefronts of every single health and care organisation in the UK. The danger is now that the pandemic is over, that some of the gains that we made again around IPC will drop off. So the leadership in an organisation is absolutely critical for us to be able to keep it at the forefront of everybody's minds. Let's look at what some of the research shows us around leadership and IPC. Now, I know when you're trying to do your assignments, you're looking at having some of the more recent literature, but some of these are quite key pieces of literature that may well help you for some of the things that you need for your assignments. And although this is 6 years old now, 7 years old now, there are still some very key things in here which are really, really important. Now, this piece of research was done in Northern Ireland. In Ireland, sorry, not in Northern Ireland. And they looked at the implementation of guidelines for MRSA and Clostridium difficile from the leadership angle. And they used a mixed methods approach of qualitative interviews and quantitative surveys, as well as action research within this. And their conclusion from this was that leaders recognise the value and innovation of guidelines to support clinical practice, but they also describe the barriers to implementation that can prevent the full uptake of these guidelines. And examples of these barriers are that they may just be an ideological approach to care, which differs from the contextual reality. So the theory-practice gap that is often talked about in nursing and in healthcare. And the reality of healthcare with resources and time doesn't always make it possible to deliver the guidelines at their ideological sense that they may be set at. So they highlighted that when there are guidelines being introduced into an organisation, they are complex. And the leaders can be the people that overcome that challenge that's posed by the complexity of this. And by using good leadership approaches to this, you can do a systematic approach to implementation, despite the variety of challenges, which may then give you better sustainability of the uptake of the guidelines over a period of time. So for this piece of research, readership really important to get the systematic approach to guideline implementation at national level down to local level. This one from 2010 is a US-based survey, research study, sorry, and they looked at the behaviours of successful leaders. It was 14 hospitals in the US, and they purposefully sampled those hospitals that were doing really, really well in their infection prevention and control and their reduction of healthcare associated infections. So they looked at qualitative data from semi-structured interviews, and then they did 48 interviews, so semi-quantitative data as well in their whole study that they did of this, and there's some more of this later to follow. So what they found from the interviews was that good leaders cultivated a culture of clinical excellence. So they expected the best out of the people that they were working with them, and they were focused on how we can be excellent in our clinical practice. They effectively communicated it to staff, and they focused on the overcoming barriers. Link this back to what the King's Fund was saying about the leaders that are there as helpers will help to overcome that. One of the really important things that the good leaders did here is they dealt with the resistant staff or the process issues that impeded the prevention of healthcare associated infection. So they didn't hide behind anything. They got out there and they supported the staff and dealt with people who were difficult. They inspired employees and they thought strategically whilst they acted locally. What that means is they used politics with a small p before crucial committee votes. They used their personal prestige to move initiatives forward, and they formed the partnerships across discipline. So they knew where they needed to be at a level of pulling people together, talking to the right people and using their knowledge and their ability to help people get on board with this. And they found that in the States, they have hospital epidemiologists, which is similar to infection preventionists as well. And they were often the people that played the most important leadership role in the success of the healthcare-associated infection programs. And that was often more than the senior executives. So moving on now, this one is also United States Hospital, a little bit more recently, and they looked particularly at hospitals with good programs around catheter-associated urinary tract infections and central line-associated bloodstream infections. So they interviewed 420 people, and that was managers and frontline staff in 18 hospitals across the US. And they were asked about their management practices for supporting HIA prevention. And they used qualitative methods to analyse those interviews to understand how those leaders operationalise their management practices to have good infection prevention and control in their settings. So what they found from these interviews, that there were 3 management practices that were characterised as the important facilitators for HAI prevention, and that's the 3 that are set out here. Engagement of the executive leadership. So whilst they might not be the most important leaders in this, it was important they were engaged in what was doing. They needed to be visible, have a commitment, and be involved. The information was really important as well. So they shared it by emails, bulletin boards, the quality huddles or the daily huddles. And their managers used a coaching style. So they gave them feedback and real-time education. And I think this is something that you will gain significantly from having the coaching on this course, is it will help you to understand how coaching can help you to move forward and will help you to think about how you can implement this in your workplace. So moving on to Gogan et al. 2020, this is part of the previous research study. And they looked now using more semi-structured interview guides with this one. And they looked again at how they could characterize the management practices here. So they saw from this that the leadership support was really, really important. And that needed to both be the financial and the human resources, the engagement and the participating, as we've already mentioned about the improvement huddles. A key thing from this was about the recognizing success. And they gave positive feedback, they used emails, they used newsletters, they used celebrations on the units. Some of this was where people where they've done really, really well, they brought them pizzas in for their breaks. They got, if they needed a piece of equipment or something like that, they were able to provide them with that. But the celebrating bit was really, really important. And I've seen this myself in practice, where we used to do the so many days since, say, an MRSA bloodstream infection or a C. diff infection, or since a pressure sore grade 3 or 4, and we used to do the days between, and I know some places now are doing days, how many days between them pressure ulcers full stop, which is really, really good. And having that in the public domain is a really, really important celebrator as well of how well you're doing. So let's move on now to look at how you can use those in practice to influence the people that you're working with as a leader. Now, if you want to influence your senior leaders, there's some really important things to be able to be aware of. You need to know what your leaders are focused on. So link your ideas to what your leader is focused on at this point in time. Infection prevention and control is obviously a really key priority for any healthcare association. So you're already linked into that. But be clear when you're linking it across that how this links into the objectives that the organisation has set for themselves. approaching persuasion as an approach. This is about building your relationships. And if you link back to what the research shows us, it's about how you work with other colleagues, know who are the people that you need to get to. Selling your ideas subtly, knowing your audience, planning your messages accordingly, meeting with influencers ahead of time to get their support before you formally present to them as a group. Now, not an infection control example, but I'll give you an example when I was in my chief nurse role at Western General Hospital, is when I got there, the nursing workforce had been depleted for savings, and it was unsafe. And we needed to put forward a paper to the board to increase our nursing workforce. So we got it ready and prepared it all, and then we went and we sat down individually with the finance department and with our HR department, because they were the key people that I needed to know were going to support me with this. So that's about how you sell them subtly to make sure that you're there. Be prepared to defend your concept. So think about the questions, organising your pitch, anticipating the tough questions and have solid answers for them. If any of you watch The Apprentice, do watch it if you haven't when they're doing pitches, because I can guarantee you will get examples about how not to answer the questions when they're in those pitches. Sometimes they just do not read their room and they don't answer the questions appropriately. It's really funny to watch sometimes, but it will show you how not to do it. And then painting a picture of a beautiful future. So this is about being able to show what you want to do, what you're leading, any improvements you're leading, how it will make a difference to the organisation you're working, the people you're working with, or the people that you care for. So being able to show that picture. When you're influencing your colleagues, these are the key things to be aware of. Listening. So ask them for their perspectives and their advice. Thinking about your body language and your tone so that you are being open to people. Lowering your voice pitch so that you're coming across very, very calmly. Now, I am a very, very smiley person, and it's natural for me to be smiling all the time. And I came a cropper with it in my infection control career because I was smiling in a very difficult situation. Our cardiothoracic surgeons at the end of year, as always seems to happen in healthcare, there was capital investment money left over. So they'd gone out and they bought some scopes to use in their thoracic practice. What they hadn't done is taken advice from the infection prevention and control team or from the decontamination team. And they bought something that we didn't have the facilities to decontaminate it in line with manufacturer's instructions. So I was dipsy at the time and I had to issue an instruction for them to stop using it until we could resolve this. Now, they didn't like it, so the clinical director came up to our department and first went to speak to our microbiologist, who was our decontamination lead, and I came into the office and we were sitting there discussing this, and it was all going along really, really calmly and all fine, until the clinical director just suddenly got really, really cross. He said, "Look at her, she's smiling. She thinks this is really, really funny. She thinks that she's pulled one over on us." And that was just because of my natural nature about smiling. So it has made me have to think really, really carefully about when I'm in some of these challenging situations, that you've got to think about your body language there. Expertise. You're the experts on this subject. You know your subject here inside and out. So you know you'll be able to answer the difficult questions that come. Think about your strategy of how you're going to influence your colleagues. It may not be, if I take a clinical, a ward as an example, your strategy might need to be that, yes, you need to influence your ward manager, your ward sister, and your senior registered staff. But the other person that might be most important to influence is the healthcare assistant who everybody listens to. So think your strategy through about who are the important people, your colleagues, to influence. And then giving people what they want. Frame the idea as a benefit. Consider the what's in it for me. going back a long time ago, but it was about stopping people using white coats on the wards. And originally it was done in the intensive care units before it was done anywhere else. And one of the simple things that they had to do then was they had to make sure that the people that were coming into the intensive care unit had the stuff they needed without having it in their pockets, because doctors used to walk around. That's why doctors' white coats pockets were always huge, because they used to walk around with their BNF, the British National Formula in their pockets, their pens, their stethoscopes, and everything were in their pockets. It's about the what's in it for me is how do we give you something technical so you don't have to have that book in your pocket anymore. So there's always something that you can do to give the people the what's in it for me, and it doesn't have to cost as much as computers. Now, when you're communicating safety messages, it's really good to think about having it short, simple, relevant, memorable, positive, and visual, because it will have a lot more impact if you can do that. Brief messages, if you've got to remember a lot, you will never remember it. Remember that less is more, and it's got to be credible as well. Think about how coherent it is. Think about memorable words that you use. The brain is attracted to elements of symmetry and rhythm. So when we're using speech and rhythms and sets of words, and with similar endings, will always help. Think of the flu campaign prior to COVID, the flu campaign. Catch it, kill it, bin it. Encouraging people to use tissues. Very simple. 3 ways it's set up, and it had it at the end of it. Going back, I'm that old that I remember before we had to wear seatbelts in cars, and some of you may remember that. And we had a campaign then, which was clunk, click, every trip. Crossing the road, stop, look, listen. So those are the kind of things, if you want to get a message across, you need to try and think about these and how you do it. Use novelty, because our brains like something that's a little bit different as well. So you can use novelty in there, and try and be as positive as you can, because happy endings, we remember better, we prefer those than we do from negative endings. So if you're giving a presentation to your colleagues, they'll remember it better or prefer it if they come out with something positive from it than something negative. You can be visual as well with this. Think of some of the posters that you use, but the research that Dinah talked about last time, the Didier Pitet research, that showed that you need to keep changing these visual messages, because they will just become part of the background if you don't regularly do that as well. And think about the context of world that you're working in. Make it real, which is what we try to do all the time with these sessions, is to make it real to you using our examples of practice as well. Now, it is okay to use humour to convey IPC messages. And in your reference list, I have given you a reference to a really good piece of research. It is part of Didier Pitet's team as well that have done this, that showed that when people had infection prevention and control training that had some humour about it, they remembered it more than just sitting in front of plain, boring messages. So it does promote behaviour change, and it can promote that knowledge acquisition as well. And it does have a positive impact on memorising messages. And in the reference list and on this slide as well, I have given you a link to Didier Pitet's presentation that he has done on use of humour to convey IPC messages. And I would really encourage you guys to watch it, because it's really, really good. But this piece of work, like I said, it's Wolfensberger et al. In the reference list. And they did get a significantly higher response to satisfaction with the learning experience when they used humour in a video to convey the message. So please do use humour in communicating your IPC. Also, please think about your interactive training ideas. These are just some of the interactive training ideas that you can use. Participative activities. I've seen it suggested that you get people to put on gloves and aprons and then contaminate them with shaving foam and use masks as well, because that's really, really interesting then if you do that. And then if you put shaving foam on the apron, and on the gloves as well, that could be a little bit of fun, and then get them to try and remove their protective clothing without getting the shaving foam anywhere else. I'm sure you've all used the glow germ boxes where you use the reflective glow to show how people can wash their hands. Isolating iris is one that I've done in the past, and it's when we had miraculously an empty room that was out of use for a while, and we set it up with a dummy in there with infection control infractions. So, for example, they had a cannula in that had been in longer than 3 days and not been monitored. The catheter bag was on the floor, some really obvious things, and then got people to come in there and look at them. There were some less obvious things in there as well. And then we gave prizes for people that could identify them all. Quizzes are always good to do. And you can do card games. There used to be one years ago that was called Match the Microbe that we used to use. You can make your own ones up, and you do it like Happy Families. So you'd say you'd have MRSA as your bacteria, then you'd ask questions about the bacteria itself. You could ask questions about how it's spread, what would be the preventive measures, and those cards would come together. Top trumps is another one that I've seen used as well, about trumping people with how transmissible your microbe that you have in your hands might be. So that's another really good way to get people engaged. And there are board games that you can buy. And in your reference list, I've given you the links again to where you can get these games or where you can find free resources on the web to help you to do this. So I'm going to stop screen sharing now. And I'm going to stop and ask if you have any questions about anything that I've covered so far. So I'm going to get you to start talking now before we go into group work and you do your presentations. I'm going to ask if any of you have got any examples of any of the examples that I've given there about the interactive training ideas that you've used that have really worked well in your settings. Deborah's put her camera on. Have you got examples, Deborah, that you've used?
We did a link day last Friday, and my session was on Think Sync. And I didn't think that the words would do anything, but on the valuation feedback, people are, oh, I love Think Sync. It's so relevant. It's like, well, yeah. So it's you've just reiterated that those words really work. So yeah, thank you.
Thank you, Deborah. That's really helpful. See, Vicky's got her camera on. Have you got an example, Vicky?
We're going into a local school for Hand Hygiene Week this year. So we've been coming up with lots of different things like baby oil and glitter, just to make it a visual thing so that the children can actually see how far they can spread, I suppose, and trying to make it fun.
Yeah, that sounds good. Just a word of caution.
Yes, I'm all up for it.
I did that with children. And they loved their hands being glittery, so didn't want to go and wash them.
Yes, well, I'm hoping to do 4 stations, and one of them is going to be a scrub station with consultant hats and scrub kits. So hopefully that'll be the last one for them.
Oh, they'll love that. That was completely unexpected to me, taking the glitter in. It's like, no, we like this glitter on our hands.
No, it's my son's school as well, so I know it's going to be an absolute nightmare, but it would be good to get out there and do hand hygiene with the kids.
That's lovely. It just brightens it up a little bit as well, doesn't it, for you guys, not having to constantly talk to healthcare professionals about it, to be able to spread the public health message wider. That's brilliant. Anybody else got any examples of good games that you've used or quizzes or anything?
In our service, we're not actually using games, but we are looking at using a video that was produced by NHS Trust in Birmingham, It models a chain of infections, how infections are transferred from a staff member to patients to visitors. So it drives in the reason why we should be compliant with hand hygiene and IPC policies. It's a visual audio thing.
Yeah. I think it is about getting it right, and it's very easy to fall into a trap of one presentation fits all.
Yeah.
And my experience when you're trying to get your compliance with training figures up is that actually if you think differently sometimes, you can get your training figures up without it being a real headache for the infection prevention and control team.
Yeah,
And
definitely.
we did have different presentations for the medics than we did for the nurses, than we did for the support staff. So we did different sessions. We thought that was better value for us than having like some of how the organizations work is your ongoing training, your update training, they just have a day and everybody comes to it. I think you lose a little bit of some of the value when you do that. And we were really struggling in when I worked at the Bristol Royal Infirmary to get our consultants on board with the infection control training. And what we did is we did a PowerPoint for them in the end. And it was one that they could sit and watch within about 5-10 minutes.
Yeah, that's good.
And it had the key points for them.
That's the ultimate thing, the key points, yeah.
The key points that they needed to know. It didn't have all the usual waffle that we sometimes put in there, but we did it, and it was like, right, this is what you need to know about what's going on with IPC in the organization at the moment. This is what you need to know about what we're doing about, we had a problem with C. diff at the time. So this is what you need to know about C. diff. This is what we need you to do. And they loved it.
Yeah, short and informative.
Short and informative. It doesn't have to be all the details. Or that's my opinion. I don't think you have to go into significant detail.
Yeah.
Over and over again. But I've also played the games with people like healthcare assistants. They loved the matching the microbe games. They loved the quizzes and all that kind of thing. And it really, really, really engaged them. So hopefully that's given you some ideas about how you can move forward with your information about the improvements that you want to make having done this course. What I'm going to do now is I'm going to get you to go into your groups. I'm just seeing how many have we got this morning. We've got 16, is that right, Crystal? Oh no, 15. There's 3 of us, isn't there? Yeah. So Crystal, could we go into 3 groups of 5? It's at random. And in your groups, I want you to do your elevator pitch for, we'll give you 10 minutes. That gives you 2 minutes each. It doesn't matter if you don't, if you take, no, let's give them 15 minutes. I think we're all right for time at the moment. Let's give them 15 minutes. So go into your groups, do your elevator pitch on what you want to change or what your assignment is about, and then give each other some constructive feedback. This is about being constructive. We're not coming back to do feedback to the whole group. This is about you working in small groups. So when you're ready, Crystal, take turns to present your elevator pitch, listen to your colleagues and give the constructive feedback on any improvements they could make. So I hope you guys found that useful. The idea of you doing that is to give you a chance to practice your elevator pitch, but also to give you a little bit of a sense about what everybody else is doing, because there may be people that are doing something similar that you, or that are doing improvements that you thought, oh, so that hopefully it makes a little bit of a community for you that if you might want to keep in touch with people afterwards that are doing similar, that you can get ideas from as well. So that's the end of your session on leadership and communication in IP&C. What we're going to do now is we're going to have a 15-minute break. Oh, everybody's rejoining us, which is lovely. Thank you. I was just saying, I hope you found that useful to practice your speeches, but also to get an idea of what everyone else is doing, so that if some of you are doing something similar, you may be able to share ideas and support each other with that. So that's the end of your leadership session. On the slide set, there is a summary, but I'm not going to go through the rigmarole of resharing the screen just to show you what the summary of it all is. We're now going to stop and have a 15-minute break before we come back for the session on recognising and managing outbreaks. So if you can come back, my clock is saying it's 10:24. So if you can come back at 22:11, that would be great. Obviously, pop your cameras on as usual, or pop in the chat so that we know you're back. That'd be fantastic. Thank you. Thank you for popping that in there, Crystal. So that we're ready to. Thank you. So I'm going to hand you over now to Monet Marinas, who is the RCM professional lead for infection prevention and control. I think that's a part-time role, isn't it, Monet? And your other part of your role is as the lead nurse for infection prevention and control and for antimicrobial stewardship. Is that right? Yeah, at the Royal Hospital for Neuro Disability. And Monet is going to give us our session on recognising and managing outbreaks. And I know Monet has had plenty of experience in the past on this, as most of us in infection control have, and led the COVID outbreak investigations in management in her organisation. So over to you, Monet, and I think Crystal's going to share your slides when you are ready.
Thanks, Crystal. So before we start, I'd like to just do a disclaimer. This session is usually delivered by one of our colleagues from the UK HSA. So today I'm going to try and step in and deliver the content as much as I can. And before we start, I'd like to just let everybody know from previous experience, and we're all infection control nurses and lead persons here. No two outbreaks are the same. So we might have heard before and things might look familiar, but it's always good to have an open mind and have that openness to listen to what other people would share to us. You are as important as everyone else who are in the leadership position in government or other agencies. So don't underestimate your role in outbreak recognition and management. So I guess let's start, if that's okay. Next slide, please, Crystal. So we can try and do a recap on surveillance, because I think it's important for us to know the backbone for an outbreak recognition. And in this session, I will try and put us in a framework or in a frame wherein we can look at an overview of how surveillance help us and how it is important in terms of outbreak management. And maybe, in our discussions, I would say discussions because I'd like it to be interactive if possible, knowing that surveillance has a purpose. It has to have a meaning. Otherwise, why would we do it? Okay, so data collection without planning to do something about it is just an exercise. If you want to do something out of the data you're gathering, then that's surveillance for improvement or for revision of your existing systems. Does that make sense? Okay, next, please. So what does surveillance mean in practice? We heard surveillance in different contexts before, and in infection control, it's knowing that we have health information available to us, a data that would show us information on population health status. It tells us the trends on certain local or regional or national, international demographics. It is, like I said and mentioned a while ago, it's only good if it has a purpose, if we want to do something about it. An example of this is a lot of the hospital, acute hospital, will do MRSA screening on admission. Does that sound familiar for you guys? And we ask ourselves, do we have to do it? And the answer for majority of our tertiary hospitals and IPC colleagues in this acute hospital is yes, because if the patient is positive, we intend to do something about it. Even if it's colonization, we do the decolonization program. So in that sense, that surveillance is important for making sure that the health and experience of our patient is better. In terms of, does everybody need to know about the information that we are gathering? So use your data to inform and not to agitate or make the population anxious. So in terms of, for example, if you're working in a community or if you're working in schools, or it doesn't matter which area you're working, what information is important and what information should be on the back burner. So if you're working in schools and you have noted that you have high number, when I say high number, it depends on your population, of kids who are overweight on your standards, what do you need to do with that information? Do you have to highlight it, or do you want to use that as a health promotion? It's up to you how you want to use the data, but think about what outcome would you like in terms of disseminating this information. Next, please. Okay, so you might want to ask yourself, do I want to do a surveillance? It's not about wanting, it's about knowing when it's needed to be done. So it is important that surveillance will allow you to make improvements or to see the trends or to make our service better. When we say surveillance, it's not just about infection, it's not just about people, it's about something that is not there before and that you picked up. So let's take, for example, in community practices, you are working with people in their own households and you're looking after them, and you pick up, oh, this week I have seen 3 patients who are confused. Does it mean infection right away? Maybe not. Maybe it's part of aging, maybe it's part of dementia, but you have noticed something different in your group of patients that you're looking after. What do you do with that information? You collate, you communicate it with other people because they may know something you don't, and that information is key or the last part of the puzzle they're trying to solve. Is it a public concern? Is it local, or is it bigger problem? In most cases, probably not, but in some cases, it's an important part or information in managing diseases in a specific area. So I can give you an example for this one, and you can tell me, or you can raise your hand and give us an example. I'm happy with that. Chris and Crystal, I can't see the people in the class, but maybe if you see somebody raising their hand, you'll give me a nudge.
Will do.
Okay? Thank you. So let's give you a quick example of this. So we have, in my line of work before RCN, I work closely with my local ICBs, and we have meetings quarterly, monthly, or as needed. So we have colleagues from the community who would always say, hey, I have an increased number of patients who are getting confused in summer, only summer, in winter, no. So we had to look at it from a point of, are they in the same area? Are they in the same age group? What is the basis of confusion? So you see, you have to ask simple questions to see if there is a correlation among this population. And because we are coming from different settings, so I come from a rehab setting, neurodisability setting, others will come from community, others will come from an acute hospital. Some of the things discussed may not mean anything to us, but putting them together, as they see now, these confused patients from community are admitted to hospital. And because of that, they are managed in a way that symptoms have presented. But having that communication platform for us, we realized 6 months down the line that hydration is one of the key things that is not forgotten, but not being put into the highest priority in terms of health teaching of people in the community. So out of that discussion, out of that simple surveillance, not a formal surveillance, we were able to establish that we can put hydration and nutrition as part of health promotion in Southwest London community. Through that, we also recognize that having a good hydration program will reduce the risk of UTI in this group of people. So we are not just using surveillance as a means of identifying problems or issues. We are using it to help us provide a better program for a specific or targeted group. And how do we know that this is exactly the problem? Initially, we don't. But what we know is that once we start sharing, people will come and tell us stories about, oh yes, we had the same thing. So lessons learned here is that never underestimate what you have seen and identified as a new issue, because it might be new to you, but it might have been an ongoing problem or issue or program elsewhere, and you don't have to do the hard work. You just have to collaborate and work with other agencies and people. So in terms of detecting and responding to epidemics, I guess this is a greater scale. It can be local, it can be regional, it can be national. What do you do when you see something new trending in your area? So normally you will escalate, correct? You will inform other people. If you are not sure, then involve other agencies. We have access to our local health protection team if we're not sure. Inquiries, reporting, that's their domain. So don't feel like, oh, it's only one case, it's only 2 cases. They might think that I'm just an annoying person. Don't, because they can tell you if they can help or for monitoring or for anything else. As infection control practitioners, we also have societies and network. You might want to use them as a discussion group or networking group if you didn't want to go outside bigger agencies. But it is important that you don't keep it to yourself if you have that feeling that it is new and it can mean something. Next slide, please, Crystal. Okay, so public health surveillance, this is in a bigger scale. The World Health Organization is one body that would collate international incidences, international alerts, diseases that are emerging. So just like us in the UK, we have 4 countries. We have regional, we have national reporting, and UK HSA will be the one looking at this data and establishing, is it worth sharing? Is it a problem? What do we do about it? So same with World Health Organization. Do you remember Zika virus? Do you remember Ebola? So the reason why we know about them is because they were reported by these countries. They were monitored by these countries, and World Health Organization are the ones who now then make national, international policies that we can adopt locally. So what does it mean for UK if there's an emerging problem of Zika virus, or there's an emerging problem of malaria elsewhere? We're probably not inclined to do anything about it, but it is important that you know what to look out for. So for example, people travel now and they might contract it elsewhere where there's an epidemic, where there's a problem, and they come back to us. And it's important that, you know, in your data collection, in your data gathering, you can include questions like, do you have recent or traveled recently in these areas, when you know that the symptoms fit into these cases. What else? So the World Health Organization, they're responsible in making sure that they declare outbreaks, you know, epidemics, pandemics. It's a good resource if you know what is happening around and outside the UK when you're developing policies. They're good resources as well. They're very robust in terms of what can you do and how do you want to use their policy into your local policy. Next, please.
Sorry, it's just opened the link instead. There we go.
Thank you. So in the UK, we have our own surveillance programs. You must have, maybe some of you are involved in the mandatory surveillance for the UK HSA. You report monthly on healthcare associated infections, SSIs or surgical site infections. This two surveillance, they are important because they have evolved. Initially, the HCAI reporting was only MRSA and MSSA. This is in response to the growing problem of MRSA bacteremia in early 2000. So it started off as curving the incidence, or making sure that we have the cases. But what we learned from this surveillance is that a lot of the things that happen in hospital does not necessarily mean that they develop there, that there are community cases translating to hospital cases. And it has given us the opportunity to improve the screening process. It has given us the opportunity to look at what can we do pre-op for our surgical patients. So some of you may have experience in assessing patients going for surgery, or assisting your patients from other hospital going to major surgery, and they require you to screen your patients for MRSA 3 days before or 5 days before, and you start wondering, what's the point of that? So that's because we want to make sure that when people go to surgery, where they will be exposed in their skin, and there's a risk of MRSA transmission from skin carriage to organs, we can do something about it and reduce that risk for the patient. So there's value in that. And we recognize that as we evolve in getting better with one or two aspects of healthcare associated infections, there are also other things that we need to look at. So gram-negative bacteremia surveillance was included into this mandatory surveillance because we know that E. coli, Klebsiella, they are becoming part of the problem, not only because of infection control practices or demographic practices, because there's an antimicrobial resistance problem that not all of us are aware of during that time. And this now comprised 5 surveillance that is important to our practice. With this, we are able to detect and develop antimicrobial policies, local guidelines on what to use when we have patients who have these problems. So it is important that we do and continue to see evolving problems so we can do something about it. Surgical site infections. So as you know, during my time, I'm not trying to give away my age, but hip replacement or knee replacement takes about 2 weeks of hospitalization. Now, a friend of mine had a hip replacement 18 months ago, and it was a day case. So science is really good and we're evolving, but what also we need to see that when the turnover of procedures are getting quicker, that we are not compromising the pre-procedure preparations. And surgical site infection is a good way of assessing effectiveness of how we move from a conventional procedure to a more elective and faster turnover. ESPOR, you might have heard about English Surveillance Program for Antimicrobial Utilization and Assistance. They publish, so this is a surveillance on the prescribing and usage of antibiotics, and they publish an annual report. So in this surveillance, they look at, are we prescribing properly? Is it the right empirical treatment without the lab reports? And if not, can we do better? So in the previous ESPOR reports, they've recognized that community UTIs, we are treating them empirically with trimethoprim, and we found out that in the surveillance, in treatment plans, it's no longer the best treatment, first line of treatment. So we are now using nitrofurantoin, and that is recommended in our target programs. NICE have recently updated their recommendations as well. So you can see how valuable surveillance is, because it doesn't only affect one aspect of care, it also extends to what we can do, because not everyone will have access to policies in acute hospital, policies in community, policies in schools, but we have access to where it's originally from. And this is a public data that you can Google, or you can go to gov.uk and see how the evolution of recommendation took place. Next slide, please. Okay. So this may seem like a long list for you, but it's just a matter of giving us tips. I say us because I also have roles in terms of surveillance in my own current practice. So surveillance should concentrate on issues of local importance to improve practice. Why do we need to remember this? So taking in consideration that we have different practices. So you might hear, oh, Southwest London, they're doing surveillance on, let's just say, for example, PVL, MRSA. So if you're from other side or other region, do you want to do the same thing? So I guess the first question you need to ask is, why are they doing it? And if they're doing it because they have increased incidence in sports people or children who are doing sports, do you have the same demographic? If the answer is yes, then go to the next question, like, do you have a problem? Do you have a reported cases of this? And so on and so forth. And if you derive to the conclusion that actually the answer majority is no, then you don't have to. But maybe you have a local issue that you can do your own surveillance. So for example, we had cases of, I forgot what it's called now, airport malaria. Have you heard of that? So in 2000 and 2017, Public Health England have started to look at what they call malaria, airport malaria. So 5-mile radius within airports, they have been detecting malaria cases. And on investigation, no one from these people who are having malaria have traveled to countries where malaria was a problem. 18 months down the line, they realized that in malaria, you have to be bitten by mosquito. So some of the luggages coming from these countries may have the eggs, and then they mature, and then they fly around within the 5-mile radius of airports. They bit people. That's how some of these cases got them. And it's important because malaria is never, well, I wouldn't say never, but was not a usual case that you detect in the UK. But the investigation is quite an eye-opener, because never say no to something that is not there before. But it's not you're not the only one responsible for this. Our responsibility is, if you see something new, you escalate and you report and you collaborate. Second tip, develop a set of surveillance criteria and use them to review existing systems. So, for example, UTI in the community. What does UTI mean in community patients? I use community because in comparison to acute hospital have ready access to laboratory. So you would know, is it a true UTI or is it suspected UTI? So in the community, according to your surveillance criteria, is it a dipstick? Is it 1, 2, or 3 of the listed categories of symptoms in the toolkit? What is it? So that when you're trying to share your data, or when you wanted to put a report together, you're very clear of what these cases are. Ensure that you ensure best use of current resources. The standards you use for surveillance are there, and it will facilitate the integration of national and local systems. So in here, for example, if we're working with clients in the UK, or if you're working with patients who are from abroad, treated here acutely but going home, what are the resources that you need? What policies would you apply? What set of assessments should be applied so that your surveillance is, I wouldn't say accurate, but appropriate to the group of patients that you're trying to see. So if surveillance data will be used as performance management, you need to make sure that they are stratified. So an example of this is, if you are working in an organization or in a trust where you want to see if the number of C. difficile, the decline of C. difficile cases means that your infection control practices is great, or your action plan is working, be very careful, because remember, your cases will vary. It won't be the same patients, same people that you will be dealing with. So when you do your surveillance data and benchmark it with performance management, it has to have parameters. It has to show that you're only measuring it with certain and specific things. You cannot generalize it. So for example, C. difficile in an acute hospital cut into half, what does that mean? Does it mean that your population is the same? You're basing it on 1,000 bed capacity all the time? Or maybe the numbers drop into half because you've closed half of the hospital. So something like that. It has to have a robust comparison in making sure that your data report is valid. seeking epidemiological services. This is important. In my previous outbreak management involvement, as a young infection control nurse years ago, I get anxious when I am told, oh, we have 5 Acinetobacter in a 12-bed ventilator unit. And it's like, oh my God, what is this? It's nearly half of our population. So in my experience, it is important, and there's value in finding out, are they actually related? Because Acinetobacter, just like people, they have different species. And antibiogram initially, and now we have other systems to detect if they are related. So please utilize them. You have support from the lab, you have support from my microbiologists. You can reach out to your colleagues and give more meaning to your cases. Feedback. Results must be rapid, accurate, easily understood. I say this because we deal with different people in our own team. I'm sure you'll agree with me that outbreak management team will involve non-clinical people. You will have your domestic people, you will have your facilities, you will have your porters, you will have your non-clinical team. So when we are giving feedback in terms of our surveillance, try and avoid using highly scientific terminologies if they have a layman's term equivalent. That would facilitate our management better, our interpretation of data better, and it can actually bring people together because we're using a language that everybody will understand. And take ownership on the improvement of patient care. So this is one thing as nurses or as clinicians that we put always at the back burner. When we have a problem, we're very good at putting ourselves forward like, hey, we have a problem. But when we solve a problem and we've done good work about it, we're very shy. Majority of the people I know, including myself, we become uncomfortable when people say, wow, job well done. Because in our heads as leaders, it's just a day job. But sometimes it's not. Sometimes it's not just a day job. Sometimes it's one thing that we do that is worth sharing. And when people acknowledge that, yes, it's a well done job, then it's worth sharing. Investment in surveillance is offset because you would know that taking or doing surveillance has a cost implication. And a lot of organizations, a lot of our leaders would say, do you really need to do that? And then you second guess. You ask yourself, do I really need to do that? Is it extra work for me? Is it going to add value to what we're going to do for this group of people, group of patients? And maybe the answer is yes. But if you think that it will improve the service and the care of your population, then go for it, because the cost is no longer your wedge. It should be something that could create this sense of, well, we're trying to save costs in the future, because if we're finding them right at the beginning, we can put management systems in place. Like I've talked about MRSA prophylaxis before surgery. If we are not actively seeking these patients who are colonized with MRSA, how are we going to manage them before they have their surgery? If people are not screened before they go into the community, how are we going to direct our health promotion to these patients? So yes, there's a cost implication, but there's a huge health benefit for these target populations. And lastly, surveillance systems should be validated to ensure that data collection is robust. So going back to UTIs, suspected UTI, remain suspected until they're validated via either lab reports or triangulating the symptoms that is presented in the clinical area, and making sure that it's not just you thinking that this is it. Collaborate, inform other people, see what's out there, and how are the others validating their surveillance. Because one of the things that happened in the past is we work in an environment where we are dealing with different people. So what might be an overweight in a group of people is just normal for other group of people, because there are other things to consider: the height, the demographics, where they're coming from, bone density, and things like that. We should make considerations for what we thought should be the standard in our population. Next, please. Okay, so this is something that we can all think about in terms of our current practice. Ask yourself, is there anything in my local area that needs surveilling? And then you ask yourself, maybe the answer is yes. What is it used for? How can I use this data? Would it mean anything to me, to my trust, to my colleagues, to my health population? And if it does, what are the outcomes? What are their outputs? What do you want to achieve for this data? Who do you want to involve? What's missing? What's the gap in the practice? And what are you going to do next? And where would you go for help? Is anyone kind enough to share their experience in this group before I go through this as an experience in my previous hospital? Not previous, but yeah. Is anyone wanting to share their experience?
No one's come on camera yet.
Okay, so well, if you allow me, I'll give you a brief example of this, so that we can just look at it from what does it really look like in a clinical area. So I was involved in an outbreak situation in an acute hospital near me back in 2018. So they have a rehab facility, and they were having a difficulty of bed turnover because nursing homes wouldn't accept patients who are CPE positive, so carbapenemase producing Enterobacteriaceae. And because not only am I wearing my infection control lead hat, I was also wearing my rehab nurse hat at the time. I was contacted by this hospital. So, well, then I went in, because that's what helping together looked like in my community of practice. And I went in there and I talked to the rehab consultants and the infection control nurses and their local CCG. And we look at what they thought was the problem. So they couldn't discharge patients because there was no one willing to accept a rehab patient going into nursing home when they have CPE colonization, not an infection, colonization. So they were screening patients, so rectal swab for resistant coliform before they discharged to nursing home, because it was one of the criteria prior to discharge. And so we started looking at, why are we doing this? So patients who go to nursing homes, they go to a single room. They go to an ensuite room, wherein if they are colonized, they will use their own facility when they poo and they pee. So what is the risk for the other patient? So the risk is that maybe when their toilet facility is not working and they use a communal one, there's a risk in there. But can they mitigate the risk? The answer is yes. So that's us without involving the nursing home or the social service side. What's the use of that if we're the only ones discussing it? So we have to bring them in and look at it from that point of view. And COVID pandemic has taught us that we are very good in terms of policy development, policy making for acute hospitals. But the social service care, the community care, they have one big policy and it's open to interpretation. So that's a lesson that we have to put into consideration when we are talking to different areas of practice. So we said, well, we're blocking beds here. We have patients who have stroke. They are in acute hospital, ICUs, medical beds, and they are not able to access rehab because we don't have the bed. So how can we help? How can this surveillance system as an issue becomes a wheel to propel change for the receiving end? We educated, we use the surveillance, we use our knowledge about CPE to train and educate our colleagues in the community, in the nursing home side. So they know what to expect, they know the transmission, they know how to manage the patients. And the outcome of that is that we have a better collaboration. So if we are to discharge patients to the community or to nursing homes, they get a full report from us, and they get where are the alert organisms, can we manage them safely? And if the answer is yes, off they go. The patient get discharged, we get to bring in new rehab patients. In terms of who is involved, what is missing, in that case scenario, in that experience, a lot of our colleagues were talking within themselves, and they were not including the people who will be more affected by our decisions. And when we bring them in, when we brought them into the picture, it was just straightforward and easy. From their line of practice, they were following guidelines. If a CPE positive patient is referred to you, do not accept because you can't manage them, period. But having been involved in that meeting, having been informed of what that surveillance looked like, they're more receptive of working together with us so that the patient experience is better. So what's next? So within the surveillance and surveillance activities, we were able to work with the neuro rehab organization and networks, and we were able to do an adaptation of the CPE framework, wherein it gives specific guidelines for the community, the primary care, the social service areas on how to manage this group of patients. And we have signposted them. Where do you go for help? Because sometimes they just need that little bit of help so that they can do their job better and properly. And I hope that makes sense. It's a very simple explanation or sharing of experience that we have, but it's not unique to one local area. It might be something that you have experienced in the past and you're not getting anywhere. Do remember that you're not alone, that you have other people, you have other agencies, you have networks that you can ask questions, and they can help. Any questions on this one?
Nothing in the chat either. I'm checking the chat.
Okay, so yeah, moving on then. Okay, so this is the part wherein everybody would know this, and apologies, I know that we have changed PHE to UKHSA a couple of years back, but and I should have changed that when I was looking at the slides, but nevertheless, the definition is the same. So I'm sure by textbook, by the time that we were studying and when we go to our clinical practice, outbreak definition remained the same. So it's defined as 2 or more people experiencing the same illness or same infection within the given time frame and within a certain place. It can occur any time of the year, and because it's a very, I wouldn't say rigid, but it's a very well-defined. Sorry, I just saw something on the pop-up. How would you approach, or what would you reason? Oh, sorry. Sorry, I saw a pop-up message and then it's gone.
I've got it here.
Oh, you got it there.
Yeah, it's a question in the chat. To start a surveillance, how would you approach, or what would be your reasons to show to seniors?
Yeah, so it's quite a question that everyone has, but they remember what I said before. You sometimes second guess because you think, is it worth escalating or not? So maybe your guiding light in terms of starting a surveillance is it something new? Is it affecting the delivery of your service, or is it something that can improve your plan of action for the service you're trying to deliver? And if the answer in there is yes, then ask the question, or make a proposal. Say, I have noticed this, and I think that there's value in checking in more. They would say no, they would say yes, but be prepared to do something about the data you will be able to collect. Don't just do a surveillance and that's it. Does that make sense?
It does to me.
Okay.
Yeah,
Thank you.
Mabuba said yes, thank you.
Yes, yeah. Yeah, because going back to that, I had the same question in the past. I mean, I started my IPC role 18 years ago, and on my second year of the role, I was thinking, every quarter we have a positive Pseudomonas in our water system. Do I start checking for Pseudomonas culture? And oh my God, it bit me on the ass, because we found a lot of Pseudomonas colonization in our trachea patient. And because my organization, they're very supportive of things like this, quality improvement. So it started as, oh, we have 5 outlets with positive Pseudomonas, and these are sink taps. And then I made a proposal, should we start actively looking for Pseudomonas positive culture within our patient group? And of course, my organization said, yes, if you think there's value to it, go for it. And we did. So we started screening initially trachea patients for sputum culture and Pseudomonas. We have 70 patients with trachea, and voila, 52 had positive Pseudomonas in their culture. What am I going to do about it? So what I did is to call my microbiologist and say, could we look at this together, please? And what came out of it is that, yes, they might not be related to the 5 culture positive in our sinks and outlet, but the risk is for when this 52 trachea patient go to shower, because our patients, they are assisted in showering. So we use a shower trolley. So we use I don't know if you're familiar with the shower trolley, but it's like a stretcher. And then we shower our patient horizontally. So that surveillance has given us a leverage or data in improving our decontamination procedures. So we know that if a patient with tracheostomy is showered, there's a risk that their sputum will contaminate the shower trolley. So we've made sure that instead of using detergent wipes to clean our shower trolley in between patient use, we now have implemented to use chlorine solution so that it's safe and ready for use for the next user. So yes, if you think that there is value in doing surveillance, collaborate, escalate, make a proposal, but also be prepared to do something about it, because it can come back as a bigger problem or a bigger issue, a bigger matter that needs resolving. Hopefully that makes sense. Okay, so going back to outbreak definition, it could be that it's not within a time and space, but for example, you have cases wherein it happens every 3 months. So depending on the incubation period, they might be related, or maybe they're not, but these are the things that you have to take in consideration. So one of the things that could have a long incubation period is, I could think of hepatitis, hepatitis, hep C. It can take up to 6 months to detect from someone who's asymptomatic. So it's important that when this information are detected, they are in your patient's notes and they are on your, some would have date access, some would have incidence reports, and that they are reviewed on a regular basis. Next slide, please, Crystal. Okay, so in RHN, we have our own definition, but it's the same. It's an occurrence of more cases than what you would expect. Same thing in the same space or place, group of people in a given period of time. And as mentioned a while ago, the purpose of outbreak management is so that we can identify the source and we can implement appropriate action plans and reduce the risk of it spreading. Next, please. Okay, so WHO, it's a disease outbreak that occur, cases in a in a defined population normally can be expected in a defined community, and it can last from days to 2 weeks or years. A single case of communicable disease long absent from a population or caused by agent can also be declared as an outbreak. So you can remember Mpox. So 2 years ago, when we have identified one case in the UK, and we started doing health promotion, detection, and prophylaxis for these cases. So people are thinking, oh, we don't have a case, but why are we doing something about it? Because remember, we have other variables to consider. Traveling, people are traveling in and out of the country. We have different population group that do different things, and the transmission for Mpox is, exchange of body fluid through sexual intercourse, and these things are not clearly defined in the beginning, but once it was defined, we were able to put prophylaxis management for the high-risk group. Okay, so there was a confusion in the beginning. Is it related to men who are having sex with men, MSM, or LGBT group? So there is a risk for this group, but it's not the main criteria. The main criteria is there is a sexual intercourse risk. So it's the mode of transmission, it's not the people. And it's important as practitioners, as leaders, that we communicate and articulate that clearly to our population. Otherwise, we will go back to the 90s, wherein HIV was correlated and associated with gay people. And that's wrong. We have to move on and use the correct terminology so that we don't isolate people, we don't label people. We are using general terms that is applicable to all population, if that makes sense. Next slide, please. Okay, so more definition of terminologies that we use in practice. Incident, you heard of incident, you heard of cluster. So incident is a case wherein we investigate something that maybe never happened, or it's a new case, or maybe it's a reoccurring case in our area of practice. So an incident is always something that we look into, deep dive, look at what are the lessons learned, how did this happen, can we prevent it in the future, what are we going to do if similar things happen. And in some cases they might be isolated, but in majority of cases, if they are reportable, they are looked at from a bigger picture by other people, and they can come back and help us. A good example of this that I can share with you is that when CPE was an emerging problem in the UK, one day I was contacted by my health protection team, and they told me one of our patients has CPE, and they would like to know more about our environmental risk, our population risk, and all the other risks related to our patient. And so as an organization, we were surprised because that patient has been in our hospital for 12 years, never left the building, never left for an acute admission or something, but suddenly this patient is a person of interest by the health protection team. So what happened is that across Southwest London, they have identified an alert organism, and due to that lab referencing in the lab, they attributed one of that case is in our hospital. So what happened is they saw an increasing number of CPE, and one of the cases that they have identified came from us. So when they realized this patient has never left our building, never had any procedure in the other hospitals where they are seeing the numbers, they used it as a standalone case, but nevertheless an important case. So they came to us and said, can we do swabbing of your environment, because this organism is normally found in the environment. And then they suggested, can we do CPE screening to all of your patients? And at that time, I was working closely with our consultant microbiologist. And what we said is, what if we found more and they are well and we're not going to do anything about it? What are we going to do? You know, because screening 220 patients with resistant organism via rectal swab, it's highly likely that a lot of patients will have something in their gut. But what does it matter? These bugs are normally residing in their gut. So it's not that we're resisting or we're saying no. It's just that, what are we going to do with the information that we will get? And that's an example of surveillance and meaningful data coming out of it. And I'm mentioning this because a lot of us in the clinical practice will be approached, because the government, UKHSA, they're actively looking for surveillance. And when they do, you will get involved. You have to have that confidence in asking the question, do we really need to do it? And if we do, are you going to support us in the plan of action that is needed after this? Okay, so cluster, 2 or more cases initially appear and linked in the area of residence. So you have more of the same kind of issue, the same kind of disease within the defined place, and also have to investigate. So you will hear this in your clinical area, you will see this in the reports, and that's just giving you a context on the meaning when it comes to what does UKHSA use this terminologies for. Next, please. Okay, So healthcare-associated infections, you know all about this. So it's an infection that will be acquired either from direct healthcare intervention or just by attending hospitalization. It is contracted. So for example, you have a patient from the community who went in for maybe insertion of catheter, and suprapubic catheter, and then when they got discharged, they developed C. difficile, infection. So it might be as a direct result of antibiotic treatment, or maybe they were in a ward where they have an outbreak of C. difficile. So that's healthcare associated infection, because it's something that they didn't have before they have the healthcare intervention. A lot of these healthcare-associated infections are preventable, and it is important to identify the systems or the mechanisms that we can put in place so that we reduce the incidence of HCAI. Next, please. Okay, so there are a lot of things that we can do for outbreak management, and it's easy for us to make our own checklist, but please do know that there is a national and government guidance on how to manage outbreak. It just gives you a template of what to do so that you don't miss the important things in terms of managing it in your local areas. So in terms of outbreak management, like I said a while ago, do not underestimate your role, and don't think that you're the only one who will be responsible in managing it. There are other people around you that you can use as a resource and help and access them, okay? Because in terms of outbreak management, it's good when you have defined roles. Otherwise, if you're doing everything, you might miss something. Okay, so let's move on to the next slide, because I think then we can have a better discussion. So in terms of outbreak management, you need to know what your case is, your case definition. For you to say, I have a problem, you need to know what that problem is. So what is your case definition? Let's take, for example, maybe in a school or in a community. If you're a community nurse or if you're a district nurse, you're seeing that a couple of your patients have infected wounds. Okay, so maybe some of our district nurses, they have a specialized role. So if you're the tissue viability nurse, or you're the bladder and bowel specialist nurse in the community, you tend to see the trends yourself. So is it usual? It's unusual? You start thinking about your case definition. And then once you've established that it is a case, or it might be a case, try and identify the source. So let's say, for example, as a community nurse or as a district nurse, you've noted 3 out of your 15 patients with wounds have a distinct symptom, or the odor is the same, the color, the presentation of the wound is the same, and it's within the same area, because usually you will cover the same area, a region or your area. Are they related? What is common? What is getting in contact with that wound that could have caused the same clinical presentation? So for example, if you have patient with wounds and they're oozing and it's green, the pus is green, or the odor is the same, what could it be? Are you the only one changing the dressing? Is there anyone changing the dressing of these patients? What do they know about their wounds? What are the locations of their wounds? Because, for example, if these wounds are in the sacral area, obviously the proximity to of the wound to the rectum and the discharge of bowels, that increases the risk of wound contamination. So you start to look at, is it normal? Well, I wouldn't say normal. Is it possible that sacral wounds will get infected with the bugs that will normally be excreted via the bowels? And that would help you. Is it an outbreak? Is it not? Because if, for example, the wounds are on the legs and they're away from a potential source of infection, and then you're getting them, then you start to think bigger picture. So 5 leg ulcers, 5 new incidences within the specific time frame, within the specific place. Is it the water source? Is it, is it a practice problem? Is it a healthcare worker problem? Is it patient group problem? It will help you. So then reduce illness and complication to prevent death and public safety. So that's one of the principles as well. Once you've detected your case definition, once you've identified potential source, I wouldn't say that it's probably the source. So if you have narrowed it down to a potential source, you can do something about it. And by doing something about it, you're reducing the problem. You're improving the outcome of the patient group. And you are able to share this information widely to increase public safety. And which tie into the next one, which is inform and learn, sharing outcomes. Don't be shy, share your outcomes, increase your resource and network by making people know that you have this problem and this is what you did. What else are they doing if they had the same problem? Share. Evaluate existing policies, because it means that it might just be 5 cases of infected wound, but maybe instead of using tap water, maybe you would now start recommending saline, or you can sterile water. I'm not sure what you can do something about it. But if you know the source and there's value in changing the current practice, then it's for public health and safety. And then what do you do with that information? Do you make a report? Who should know the report? How do we share it publicly without increasing the anxiety of people? Because what you don't want is they would say, oh, people in Hackney or people in Putney are at high risk of wound infection. You don't want that, just because that in your report you say, we have noted increased incidence of wound in this region or in this public place. Maybe just changing the words and the narratives would increase, increase the confidence of those who are reading it, and that they would see it as it is and not as associated with a certain practice and certain population, if that makes sense. Next, please. Okay, Chris, can I ask, how am I with the time?
Sorry, just coming back onto you're fine.
I'm fine.
Because we've got time at the end, so don't worry about your timing. Just
okay, give me a nudge if
I will.
if I'm over time or over talking. Thank you.
Okay.
So just a recap on what we have just discussed. This is the framework of outbreak control, and this is based on the UK HSA template and WHO. And for those of you who have been involved in outbreak control, you know that this is part of the template where your health protection team will come and they would discuss this one by one with you. So they would like to know case definition. Is it really a case? When did this happen? When did this start? How did you recognize it? Who are these cases? Confirming diagnosis. So for example, we have, let's talk about this, a specific example. So for example, you have let's use my Pseudomonas in the trachea patient because we have involved HPT at that time. So case definition, we know that we have increased incidence of Pseudomonas in our trachea patient. It's confirmed because we have laboratory tests to confirm it, and we have demographics to support our theory that patients who have tracheostomy are at risk of, having or colonization of Pseudomonas, because Pseudomonas is an organism that likes plastic. They like wet and moist areas, blah, 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 da, 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 da. So that's your background of incidence. Case finding. So we've mentioned a while ago, be prepared for the result of or the outcome when you start to find cases. Do not be limited with, oh, I'm gonna try and seek cases, but I'm not prepared to do something about it. So that is not the culture you want to foster when you want to know what's out there, in addition to what you've already found out. Data collection. So make sure that you are using a system that is acceptable. So a lot of us now have moved to electronic data. Some are still on paper trail. Privacy and confidentiality is very important. This is something that we have identified as a risk in terms of using pen and paper. And it's the same thing with electronic data, because they can easily be hacked. But be very, very careful and use your local policies in managing this information, because they are patients' information. They're not our own one. They didn't consent for their information to be shared widely. So make sure that you follow your own local policy in terms of using data. Use descriptive epidemiology methods. So we talked about things that happens outside the UK and things like that. Consider these cases. They are unique people. They might have lifestyles. They might have moved from one place to another. This is what you call descriptive epidemiology. So know what, besides the illness, besides the disease, the organism, what else is important that is unique to these people? Because 5 people might have malaria, but it doesn't mean that they like outdoors or they like other things. So it's important that you treat each case as an individual case, and help you with this, finding out their whereabouts, their lifestyle, where they live, how do they interact with people is important, because that's going to help you when it comes to giving recommendation and advice. Microbiological investigation, it is important because it gives you a bigger picture. Years ago, we didn't have this, well, I say years ago, maybe decades ago, when we send specimen to the lab, they would do their normal microscopy, and everything else. Now we have PCR, we have advanced technology to identify if organisms are really related, or because you can say Pseudomonas, but there's hundreds of types. You can say Acinetobacter and you have hundreds of types. Having 100 cases of Acinetobacter in a 1,000 bed hospital doesn't mean you have an outbreak. It just means that they have a species of organism that is probably innate to the building, and that's what microbiological investigation is for. They would help you identify if these cases are related, if they are, if there is an ongoing transmission, because maybe it's not. Before, simple antibiogram can help us do that. So what it means for antibiogram is if you have 10 cases of Pseudomonas, but 2 of them are sensitive to one antibiotic, 5 of them are resistant to one antibiotic, then it means they're not the same species. Does that make sense? I hope it does. But if it doesn't, just give me a buzz, and I can give a more information or explanation. Environmental investigation. So this is quite the trend in early 2000, because we always attribute that if patient gets something that is in the hospital, it might be in their environment. So there was this trend in the past wherein we swab all curtains, we swab the sink, we swab the drain. This is no longer something that we do, because one, there's no assurance that it's related to the existing problems on our patient. So swabbing a sink doesn't tell you anything, but that sink is contaminated. And of course it is, because everything goes down the drain. It doesn't matter if you put, do not pour your drink here, it's a hand hygiene sink. A minute later, you will see people putting their tea, leftover tea, leftover coffee in a hand hygiene sink. So just accept the fact that all sink drainage will be contaminated. So if you swab that sink, you're bound to find something. And if it so happened that it's the same bag as what your patient have, you will be inclined to say, is there a correlation? Highly likely, no. But because you found it, you now have to investigate. Does that make sense? Hypothesis generation. So for example, you now have cases, you now start to think, is it related to environment? Is it related to demographic? Is it related to season? Is it something that is emerging in this particular age or gender? You start to formulate them, but don't limit yourself in those kind of hypotheses. If something else comes up and it's not within your hypothesis, don't dismiss it. Just put it as part of your investigation. Analytical epidemiology. So we talk about systems in place. Is it valid? Are you collaborating it with local agencies, with health protection agency, to make sure that you're not missing anything and you're guided by what should be done in terms of outbreak control? Communications. This is very important. We will all remember during COVID pandemic that communication has played a big role in compliance and anxiety of the public. So have that as part of your meeting, incident meeting, outbreak meeting. Agree on what you would want to tell stakeholders, or information to share to other agencies, and information that you will give to public. So they might be the same thing, but delivered in different levels, if that makes sense. So for example, what do you want to tell? If you have an increased Pseudomonas cases in your patient rooms, what do you tell your commissioners? What do you tell your ICBs? What do you tell your family and relatives? What do you tell your local council? Because their actions should be appropriate to what they can help with. So informing the relatives about how they should, care for the environment or look after their patient, report if they have fever, that's specific to them. They don't need to know that, oh, so what we can do is then we will have, instead of quarterly testing of water in this area, we'll be having every 2 months. They don't need to know that, the relatives and family, because they can't do anything about it. They will just have to increase their anxiety and waiting. Oh gosh, it's the 2nd month now. What does it mean for us? Okay. And in terms of commissioners and funders, they would know that the care need of this patient will be more compared to their usual care needs. So maybe this patient used to have 3 visits from healthcare workers. Maybe because of this, they would be needing 4 or 5 visits. So communications is vital. It's important, and it should be something that is well thought of. It shouldn't be just like, oh gosh, I have 5 cases, let me inform this person. In an outbreak management team, it is important that you have the same briefing, the same message, and you're looking at the same data set so that your actions are synchronized and you're evaluating the same thing. In terms of, I can see, infection control, don't limit yourself to what is available to you. If you think that there is more that needs to be done, then you need to highlight it. So for example, in terms of C. diff outbreak in one of the units, in one of the wards, if you think that to increase turnover and disinfection, you would need ultraviolet light to help you with, making sure that the turnover of patient can be better, then, recommend it. Put it in there, and contact local agencies and help you think through all the new things or processes that you want to put in place. Next, please. So these are just the methods in terms of your approach in your surveillance or case finding or outbreak management. Epidemiological approach, so knowing the population, seeing what is available information for you. Active case finding, so this is when you start to look for more cases, if there are any in your patient population. Prospective studies, so you now have a case. Do you want to see if any more cases would arise or develop? Retrospective, so you have a case today. You want to maybe look back 6 months ago or 12 months previously, were there cases that we missed? Cohort studies, so you will look at cases who have them, a group of patients who have them and group of patients who don't have them, compare their variables, their demographics, epidemiological characteristics. Case control studies, this is good if you can or if you have access to them. Comparison groups, so just be very careful when you're looking at these methods, because it's easy to just think that we can compare one group from other groups. Remember what I said in the beginning, no 2 outbreaks are the same because you have different variables, you have different people involved in these outbreaks. So it's good to have them as, as reference, but don't be inclined to limit yourself because that's what's available for you. You will always find that you have a unique population that you're working with. Statistical evaluation, attack rate ratios, these are the things that you will see if you're reading papers, if you're reading reports. And like I said, have that kind of, how can I put it in words? They are there, but it doesn't necessarily mean that it's applicable to you and your case, if that makes sense. Okay, next slide, please. Risk assessment. So everybody is, I'm sure everyone is familiar with risk assessment. Risk assessment is the backbone of our clinical practice. Knowing, so first is, if you have a case or you have a case index or you've identified or suspected a case, it's important that you establish the route of transmission, because knowing the route of transmission enables you to prioritize control measures that you have in place. So for example, is it a respiratory transmission? So what can you do about it? So while you're doing and planning, you can put in place maybe barriers, mask, isolation, decontamination, physical distance if needed. Patient loads. What are the patients? Who are these patients that are affected? Are they hospital setting? Are they community setting? What's the response like from your group of patients? Because sometimes you would say, in the community, I have a group of patients who have TB, tuberculosis, and it's important that within their first 2 weeks of treatment, they would be isolated, or they should be physically distanced from either household or the community. But if you have a patient who needs to work, because if they don't work, they don't get paid, these are the things that we need to consider. And a discussion needs to be made, and they must be supported so that they can comply and not expose others to their diseases. Environmental persistence. So we would look at what are the risk factors in terms of, so for example, during cases of flu, what are the things that we can do to negate the transmission process? Colonized infectious state, are they colonized? Is it a risk? Can they do as business as usual? If they are in their infectious state, like we said a while ago with the TB, how can we support these people for them to comply? We have a case of multi-drug resistant TB couple of years back. So a family member went to have an outreach program in one of the African countries, came back feeling feverish and everything else, disregarded it, thinking it was just feeling of tiredness. And then 2 weeks later, he was diagnosed with multi-drug resistant TB. And because of that, we have to inform, well, I'd say we, because I was involved, the health protection team has to involve the airlines, because he flew within that period, so that they can do contact tracing. And then we have to inform the workplace, because he's been in contact with other people and other patients. It's a consideration of the people around the person infected, because the risk for other people is present. It's an open TB, and it's within the incubation period. The risk is there. So timing of infection, like we said, there's incubation period. This person develops symptoms 2 weeks later after contracting it abroad. So within that 2 weeks, are they infectious? Are they able to transmit it to other people? That's the responsibility of health protection team, because this is a notifiable disease. But your responsibility is to be able to facilitate that for your patient, so that they are honest and open, that they can give exactly or describe what happened in the last 2 weeks or the last 4 weeks, whatever timeline that your health protection team requires you to recall. Endogenous versus exogenous. So it's just something like, did they have it or did they acquire it? If they have it within themselves, how are they going to transmit it to other people? If they didn't have it, how did they acquire it? And then surveillance. How did you start off with this case finding? What did you see that prompted you to do what you're doing right now? So those are just your simple guiding principles to help you narrow down your assessment and action moving forward. Next, please. I'm sure everyone has seen a risk assessment matrix. They might not look like this, but in your own local practices, they would be graded so that it can direct you. Is it an urgent matter that needs to be addressed now? Or is it moderate risk that you can look at, monitor, compare with other organizations, other agencies, Or is it so low risk that it's just there, you don't do anything about it now, but you know that it is there, if that makes sense. Next, please. Again, what does it mean in practice in terms of risk assessment? Remember, we are unique in our own ways. So people, we might come from the same ethnic background, we might come from the same place, but we are different in a way that our diet, our occupation, our lifestyle is not the same. Our religious practices are not the same. So when we are looking at demographic, you don't put them as one, the same people. They are a group of people living in the same places, but may have different characteristics and behavior, practices, and culture. That's just one thing to remember if you're doing this risk assessment and epidemiological background checks for your group of people. Thank you. Next, please. I think we have discussed this into your risk assessment. It's important that when you start doing your outbreak management planning, that you are specific with the time and place, because this is very important. For example, you are looking at a case where incubation period is vital to be established and identified. When you're doing your investigation and information search, you need to explicitly ask your cases, where have you been in the last 6 weeks, 2 weeks, and did you notice anything, or blah, blah, blah. Susceptibility of the population when you're doing risk assessment. These are kind of sensitive questions to ask or informations to gather. So just put it in mind that when we're asking people, we ask them in a way that it will not put them in a situation where they can lie about it. So, or they would withdraw rather than anything, the information. So for example, MPOX. So we know that there are high risk groups, susceptible population for this. If we try and ask the questions, let's be politically correct in putting our words in there and not be seen as a way of labeling group of people. In terms of infectiousness, just be very pragmatic about your approach to information dissemination. So when we're saying TB is normally or usually transmitted via droplets, aerosol, close contact, rather than if you are in a crowded area, you will be at risk of, because those can come with two different set of answers when you're gathering, where you're doing your investigation. Clinical presentation, and in terms of outcome, some will have fatality, some will have severe consequences, but it's important that we look at the clinical presentation as reported and as clinically evidenced. It's not about, when you're doing a risk assessment, oh, the elderly, they're highly likely to die from this kind of diseases. That shouldn't be our that shouldn't be how we would communicate it. We should be very, very pragmatic with our approach, and we should be very objective about things. Diagnostic and investigation. So when you want to find out something, what do you have? So for example, we talk about UTI in the community. Is it enough to do the dipstick? When does a dipstick mean something and important? If you're trying to look for maybe proteinuria or sugar or anything, it could give value to that diagnostic. But if you're trying to look for bacterial infection or colonization of urine, that is not the best diagnostic system you need to put in place or in your investigation. Is it available to you? Maybe not. Is there anywhere else you can send that to, for example? Treatment and control. So this can vary as well in different settings. Your treatment can be different in primary care, in tertiary care, secondary care, or in the community. So make sure that you are liaising with your local agencies, you're liaising with your network, and seeing what's available. What's available is not necessarily what you need, because maybe there is better treatment option for your patient and you need to help them source it out. Referring to your GP, giving correct information, giving good assessment can help primary care put the case forward to the right level of management. Previous incident prevention measures. So you have standard measures and you have prevention measures coming or arising from your outbreak management plan or cases or cluster management plan. So let's take, for example, if you have a cluster of underweight children coming to school and you would want to put together health promotion on healthy eating or whatever, that's prevention measures as a result of your investigation or your caseloads. I can see Chris came into picture. Am I over time now?
Yeah, I just think that there's only a few slides left.
Yes.
And I think they're quite repetitive. I've had a quick look at it. I think you've covered most of it already. So I don't know if you want to just whiz through the last few and we'll give people a bit of a break.
Okay, yeah, that's fine. Yeah, you're quite right. So they're repetitive, but they're also important for you to know that they might come as exhausting list, but familiarize yourself with what you can do from the level of practice that you are in now, so that you can contribute appropriately when you have that outbreak management. So yes, next slide, please, and let's have a look at what's next. We've done this, so let's have a look at the next one. Those are just your what do you call this one, reference, and they are publicly available, so you can go to gov.uk and put the keywords that you want to find out, but they are very helpful in giving you heads up on what to do next. Next, please. Yeah, so I had a look at this slide as well. So normally our team in the UK HSA would have a very nice flowchart plan, but the next slide will show you that in terms of outbreak, things can go sideways, you know, and they can be convoluted. But what's important is that you have a role in outbreak management and you have to assert yourself and be you know, collaborative and assertive enough to identify what is missing and give and contribute to what could be done about it. And I'm sure this may look like a traffic that is not manageable, but if you have a template and you know the principles and you know your population, it makes it easier for you to manage the problem, if that makes sense. Next, please. And yes, I think that's it. So hopefully I have somehow given a little bit of a whisper in outbreak management. And if you have any questions, please don't hesitate to either contact Chris so she can direct them to me, or email me directly, and we can have that little bit of discussion.
There's comments already there. Thank you. Excellent session and everything, Monet. But I just want to make sure that we get time in for the group work. that we usually do with them. So this is absolutely perfect. So think of any questions that you might have for Monet while you pop off and have a quick break. If we can have 10 minutes, and if you can be back ready to start just before 5:30, and then we'll go into groups and do a little bit of group work on managing outbreaks.
Okay, welcome back, everyone. So the last leg of our session involves you working and then me just listening to you back. Is that okay? So I'll start with giving you a scenario, and then you will go to a breakout group wherein you will be in 3 different groups of 3 different discussion of what you can do within that group. So just giving you the scenario really. So we have an outbreak of CPE in the urine sample. So CPE, or carbapenemase producing Enterobacteriaceae, in urine samples. So 112 positive cases within a period of 18 months in a spinal unit. So 28 bed capacity, 112 cases, 18 months period. And it wasn't an issue until they stopped, because in this spinal unit, they share facility with outpatients unit. So outpatient spinal recovered, coming back for their rehab, using the hydropool, using the gym, using the OT kitchen facility or ADLs. And then they stop the outpatient group coming in on site because they have a problem of 112 cases of CPE in urine samples. So I think putting this in context, IPC nurses are in play because they are the ones who said the outpatient group is at risk because they will be mixed with patients who are colonized, infected with CPE in their urine. So, and then the management said, no, we can't afford that because 150 patients coming into our service, we are depriving them of the facility and the rehab potentials that they are getting from our facility. And then it went up to the board and higher ups and say, then what do you do about this? How do we manage this outbreak? So now I think I can talk about what happened, but I'd like you to imagine and put your imagination hat and see in your groups, within those roles, in your breakout group, how would you have done it? How would you deal with this situation to make sure that the service continues without putting patients at risk? And what does that surveillance tell you? Without me going in deeper in explaining what does that 112 cases mean, knowing that, what does it mean to you? There's no right and wrong answer. Yes, this has happened. It's a true case scenario, and it was different people. Now you're different people. Let's see how we can attack it.
So we're going to put you in. So group 1 are going to put on the hats of the executive team. So like the trust board, the director of nursing, the medical director, the operations director. You need to think that you are those people that are running the whole organization that Monet's talking about, okay? Group 2, you're going to be the infection control practitioners and teams. So that would be the microbiologist. You're the outbreak management team. So the microbiologist, the infection control nurse. You might have somebody from the laboratory in there. You might have somebody from the cleaning department and that kind of thing, or the estates department in there. And then group 3, you are going to be the people that work on that unit, the spinal unit. So you're going to be the staff. So we want you all to have a think about what this outbreak means for you, what you need to be aware of, and how you could manage this challenging situation that Monet has described. Okay, is everybody happy they know what they're doing? Yeah, Okay, so if we can go, please, Crystal, into the groups for 10 minutes. And as I said, I can see your little microphones going up and down, so that was great. So let's see group 1. Just give us a little bit of feedback about what you talked about in your group.
Group 1, it's Sinead. Shall I feedback? Okay.
Yeah,
So,
go for it, Sinead.
Okay, so we said from the executive point of view, so they may be worried about the wider stakeholders and how would it affect the hospital's image. Loss of income from non-attenders attending their outpatients. If they're not hitting their government targets for outpatients, they could possibly get a fine for it. The additional cost of cleaning the department, additional hours lost through man hours lost through attendance at meetings. So those executive team could be doing something else, but now they've got to attend all the update and post-investigation review meetings. Then also the longer impact, potentially different hospitals have to manage the condition. So just as Monet had said, it's looking at the big, huge circle. So if you haven't got a patient attending the outpatients, then you have potentially they're not going in for their surgery or for their interventions, then they haven't got a bed, then we're not able to discharge the next patient. So it's the big circle impact of that. Also, would the corporate team actually support the cost of the budget? Because if all additional cleaning was going to come out of the outpatients budget, then that is quite unfair because it hits the wider organisation. So would the corporate team help them in supporting the costs? Also, you've got an impact on staff morale. And also you would have to manage the workforce if there was redeployment involved, so that actually affects morale. And then, as Monet had said, when you need somebody to be able to stand up there, so if the Dipsy was on the team, hopefully she would be able to fight for the team and give the rationale for why they were doing the interventions.
Well, that's brilliant. I think you've covered virtually everything there, Monet. What do you think?
Yeah, I think the thing that I pick up in there is that to support your workforce. I think that's the one that really got me into, like, yes, if I have an executive team that says, how can I help you to the workforce? I think you've done your part, because as frontliners, that's what you need. That's what you need. Somebody who's saying, yes, you're doing a great job, and let me help, let us help you do your job. So yeah, if somebody has that kind of senior leadership, then you are well on the right track in terms of that management. So yeah, well done.
Most definitely. Thank you. Okay, group 2, which was the outbreak control team. So that would be the infection control people, microbiologist, estates, domestics, etc. Who's going to give us a little bit of feedback from group 2?
Would you like me to do it?
Thank you, Deborah.
We were talking about the kind of actions the team would take. So the correlation was, are they all at the same time? We'd see if we could find the index case and work from there. And we spoke about the samples. Is it common practice for the spinal team to send samples, urine samples, or were they sending them because they were symptomatic? How did they identify it? Was there a common theme? Estates and facilities, do they do a regular walk around? How do they manage the environment? Are they flushing? Are they testing the water on the hydro pool? Is that routine? Did anything change on that routine testing? Checking if there's an issue with the drains. IPC were going to find links, trace some reports back to the chief nurse, put a practice plan in place, make sure estates are doing what they're meant to do, domestic services are cleaning properly, and has the chlorine agent been activated. And I think someone said about in their hospital they've gone for chlorine wipes because it's helps cleaning. Micro, they'd help us get more in-depth knowledge about the CPE variation, if there's any antibiotic resistance, is it common? They'd help us identify it. And we were thinking, how did we identify it? Was it through surveillance that we knew there was 118 cases? And the outpatient toilets we were looking at as well, were they being cleaned properly? Are staff washing their hands? Would we do hand hygiene audits? And we'd educate them. And I'm sure we spoke about the DIPSI, and I think she'd feed back, or she or he would feed back into other groups. I think that was it. Anything, anyone want to add any more?
That's really
It's an
good.
interesting role being a DIPSI when you're in an outbreak situation, having been there, because you're almost that sandwich in the middle between stuff, because you're almost fit into the executive team bit because they want you there with things, but you're not the decision maker. But then you're with the outbreak control team bit as well. Yeah. Monet.
Yeah, so that's really good. I like the part where your group says, is it a normal practice to be, collecting this urine sample when they're asymptomatic? And you mentioned about what has changed, is there something that has changed that could have prompted the increase in incidence? And collaborating with other people in your team, that's really good, because the only time you will find out if something has changed is if you involve people who are actually involved in that environment. So yeah, good start. And I can see that if you have this kind of problem and you're asking the right questions and you're involving the right people, you can't go wrong with that. You might find yourself like, oh, do I need to inform domestic? But if you've already had that in mind, then you're on the right track. So yeah, good stuff.
And last but not least, group 3, probably the most important group. We probably should have started with these people first, the people that work at the front line. So group 3, have we got somebody that wants to tell us what you talked about? I could see your microphones were going up and down, so I know you were talking. Anybody? Sunday, I know you were in that group.
Yeah, we talked about.
Oh, Amy, thank you.
We talked about what we would do. So we try and isolate the confirmed cases, test staff who may have been exposed, isolate the people who are involved. It's not an airborne bacteria, so we felt that was quite positive, that it would be slightly easier to manage. Try and establish the route of infection. Use antibiotics as sample from a sample test for the bacteria, so make sure that we're using the right antibiotics. Isolate the patients, and then the outpatients, we would look to maybe limit the times that they're accessing the unit and the facilities that they're accessing, and make sure that everywhere's deep cleaned before and after they come in, and review to potentially get an external company in to help with the deep cleaning, to take some of the pressure and burden off the staff. And then we'd look to the policy and protocol for outbreak and make sure that we were following whatever the policy and the protocol says, and communicate with the outpatients, patients on the ward, staff, visitors, let them know what's going on, and what precautions we've put in place, and what processes we want them to follow, and make sure that the cleaning products that we're using are fit for purpose, and that they're not, they will help kill bacteria rather than allow it to just carry on growing, and link in with the senior management team, leadership team for further direction, advice, support, and ask them, if we've covered everything, and link in with the infection control nurses.
Brilliant, Monet.
Yeah, so that's good, thank you. So from the frontline point of view, you've given some good points in there. So informing your IPC, informing your, escalating it, what else can be done, because as a group, then you will get a bigger picture, because they will look at it from a vantage point, I would say. So because they would have access to the microbiology and they can give feedback to you, and then you can discuss how this is transmitted, how is it affecting your patients, and maybe they will devise some health teachings for your outpatients team, because that's a very important role for our frontliners, because you'll be the one talking to your patients and, you know, assuming that they're outpatient patients, they would have the cognitive capability to understand what's the risk for them and what they can do. So yeah, I think I kept saying this, but we have a role and a unique role in outbreak management and recognition, and don't feel that, oh, I'm only the front line, or I'm only this, or I'm only that. No, you have a unique role, and use it as a platform to escalate and to cascade information. So yeah, good, well done.
That's brilliant. That was an excellent bit of group work. I think that was really, really handy. Monet, do you have any sort of summing up things that you want to say to the group?
I think I was cheeky by starting a while ago in mentioning that no two outbreaks are the same, because I know these things happen. We run out of time and I forget to summarize. But yes, for the end time, you have a unique role and responsibility, and you have the resources and knowledge that you need. Now, the takeaway is how you're going to see yourself in practice and use your position to influence practice to the safer and better patient delivery. Right? But yeah.
Lovely, thank you, Monet. I know Monet has got to rush off to another meeting, but I'm just going to check if there are any questions before she rushes off.
If not, you can always contact me.
Yeah, we've got an email address, Monet, that they can use to get hold of the team, Bettina and Crystal. So if there are any queries, then I'm sure that specifically for you, we can direct them through to you, which will be great. That's brilliant. Thank you so much, Monet, for that presentation. That was really, and that session, that was really useful. Thank you.
Thank you. I'll see you later. Bye.
See you later. Thank you, Monet. Okay, so 1 minute to go till 1 o'clock on my computer. So are there any burning questions that anybody has before tomorrow? Oh, Crystal's put the email address up as well. Just a reminder for you that those of you that aren't doing the assignment, you can join us tomorrow at 10:55. The first session tomorrow is only for people doing the assignments with Coventry. So those of you not doing it, please feel free to join us later in the morning. And I can't believe it's the last day already with you guys. Thank you again for a great day today contributing to the sessions. And we'll see you all tomorrow.
Thank you. Thanks all.
Bye.